Imagine you're walking down a perfectly quiet, brightly lit hallway in a long-term care facility.
Right. Just a normal Tuesday.
Exactly. Totally normal Tuesday. But suddenly, the fire alarm just shrieks above your head.
Oh, wow. Yeah.
You smell burning plastic,
Yeah.
and you see this thick, gray smoke pouring out from under the door of room 3.
Terrifying.
In the next 10 seconds, the decision you make, the very first physical action you take, is literally going to determine if someone lives or dies.
It really is. There's no time to, pull a manual out of your pocket or Google the protocol.
No time at all. So what is your very first move?
Well, it's the ultimate test of nerve, isn't it? Because our human instinct in that specific fraction of a second is usually completely wrong.
Right, because we want to fight it.
Exactly. When we see smoke, our brains just scream at us to fight the threat or raise the alarm immediately. But in a healthcare setting, those natural instincts can actually get your patients killed.
And that incredibly high-stakes reality is exactly why we are here today.
Today is episode 6 of our 11-part series covering all 6 of the NNAAP written exam topics. And just as a quick reminder to you listening, every single one of these deep dives stands completely alone.
Yeah, you can jump around to whatever topic you need to conquer the most.
Exactly. But today, our absolute focus is Safety Part 2, Emergency Procedures and Fire Response.
And the gravity of this material really can't be overstated. It's critical for the actual human beings you'll be caring for, but it's also it's a massive hurdle on the exam itself.
Just a huge chunk of the test, right?
Massive.
Yeah.
If we look at the NNAAP outline, which is based directly on that NCSBN study, the broad category of basic nursing skills makes up a staggering 39% of your written exam.
Wow, 39%.
Yeah, that equates to 23 questions out of the 60 scored items.
Yep.
So safety and emergency procedures, they occupy a huge, unavoidable chunk of that territory. You really can't just memorize a few vocabulary words and skim past this section.
Definitely not.
So our mission for this deep dive is to dissect the mechanics of a crisis. We're going to explore exactly how you respond when things inevitably go sideways. Fires, natural disasters, choking, seizures.
All the scary stuff.
All of it. But more importantly, we're going to tear apart those trickiest scenario-based questions they love to throw at you on test day.
Right. We aren't just going to give you the correct answer. We want to ruthlessly interrogate the why and the how behind the protocols.
Exactly. And examine why those wrong answers on the test are designed to look so incredibly tempting.
So let's just jump right back into that fire scenario you set up a moment ago.
The smoke pouring out of room 3.
Right. You're standing in the hallway. Now, the exam writers are banking on the fact that your adrenaline is spiking and you want to do something drastic.
Like sprinting for a fire extinguisher or screaming for the charge nurse.
Exactly.
Yeah.
Because logic tells you that if you kill the fire, the danger is gone.
Makes sense on paper.
It does. But healthcare fire response is governed by a really rigid, non-negotiable sequence. You have to override that instinct.
And we use the acronym RACE for this, right? RACE?
Yes. Rescue, activate, confine, extinguish. And that order is not just a casual suggestion. It's a strict operational sequence.
So that R stands for rescue.
Always. Your very first step. Always.
Okay, so if I'm breaking down the psychology of that before I even touch a fire alarm, before I yell for help, my sole focus is the actual person currently sitting in the room with the fire.
Precisely. If a patient is in immediate, localized danger, your first physical action is to move them out of that specific room.
Right.
The distractors on the test, the incorrect options, they'll suggest things like close the windows to prevent a draft or alert staff and activate the fire alarm immediately.
Which sounds so responsible.
Right. Activating the alarm is critical, yes, but it's step 2. Pulling the alarm does not magically pull the patient out of the burning room.
Good point.
And closing windows. That's a confinement strategy. That's step 3. And attempting to extinguish the fire is the absolute last step, assuming it's even small enough to fight.
That sequence really forces you to prioritize human tissue over property.
Perfectly said.
You move the vulnerable person, then you pull the alarm to get the cavalry coming, then you shut the door to starve the fire of oxygen, and only then do you even think about fighting it.
You're completely isolating the threat while ensuring the most immediate victim is safe.
Okay, let's talk about the fighting part, though, because I really want to challenge that extinguisher step.
Go for it.
Say I walk in and the fire is tiny. It's literally just a wastebasket fire. Someone tossed a cigarette in there, and there's a pitcher of drinking water sitting right next to the bed on the nightstand.
Oh, I see where you're going.
Why wouldn't I just grab the pitcher, dump it on the trash can, and be done with the whole thing in 2 seconds?
Because you are making a massive, potentially lethal assumption about what is actually burning inside that wastebasket. Yeah. You see smoke and paper, but what if there's a discarded lithium battery in there? Or what if the fire actually started from a frayed electrical cord behind the wastebasket and the basket is just catching the collateral flames?
Ah, right. And if I throw water onto an electrical fire...
Water conducts electricity.
Yeah, that's really bad.
It doesn't just conduct it, it creates a liquid bridge directly back to you. If you throw a pitcher of water onto a live electrical fire, the current can literally travel straight up that stream of water into your body and electrocute you on the spot.
Wow.
You've just turned a small localized fire into a lethal electrical hazard, and now you're incapacitated, and the patient is still in danger.
That is terrifying. It completely changes how you look at a simple pitcher of water, which I guess brings us to the actual proper tool for the job fire extinguishers.
Exactly.
And the exam is pretty rigorous about making sure you know the difference between the types of extinguishers.
Oh, very rigorous. Actually, on the Cert Prep Academy practice tests, this specific type of question pops up constantly.
Ew, yeah, they love those.
They really love to test if you compare the correct extinguisher with the correct chemical reaction. You need to intimately know the Type C extinguisher.
Let's break down the mechanics of Type C then. Why is it so special?
Well, Type C extinguishers are specifically engineered for electrical fires. They contain non-conductive agents, usually a dry chemical powder or carbon dioxide.
Okay, so no water.
Right. Instead of cooling the fire with water, they smother it. They physically displace the oxygen that the fire needs to breathe, or they interrupt the chemical reaction of the flame itself.
And all without conducting a single volt of electricity back to the user.
Exactly.
So just to map out the whole alphabet for everyone listening, Type A is for ordinary stuff that leaves an ash, like paper or wood.
Right.
Type B is for boiling things, like flammable liquids, grease, or oil. Type D is for combustible metals, which is pretty rare in a nursing home. But Type C is your electrical fire lifesaver. So C for current or cords.
That's a solid way to memorize it. C for current. I like that.
Okay, so let's look at the broader evacuation now. You've rescued the immediate patient. You've pulled the alarm. The alarm is now echoing down the halls. How do we get everyone else out?
Because a long-term care facility is full of people who cannot walk.
Right. I would assume you follow a proximity principle. Like, you start at the epicenter of the danger and work your way outward like ripples in a pond.
You nailed it.
Yeah.
You evacuate the patients nearest to the fire first, and then you move laterally away from the danger zone, usually behind those heavy fire-rated doors in the next wing.
And there's a critical rule regarding staff here, isn't there?
There is. The staff leaves last.
Like the captain going down with the ship, you don't just run out to the parking lot to, like, direct traffic.
Exactly. You stay and systematically clear the floor. And the test will throw a very specific curveball at you regarding communication during all this chaos.
Okay, what kind of curveball?
Imagine you rush into a room to evacuate a patient, but they don't speak a word of English. The alarm is blaring, they are confused and terrified. How do you handle that?
I mean, trying to mime, "There is a fire, please calmly follow me to the designated safe zone," seems like a terrible waste of time and the room is filling with smoke.
It's a huge waste of time.
Ugh.
But the wrong answers on the exam prey on your desire to be a quote-unquote good communicator.
Oh, I see.
Yeah, they'll suggest you should leave the patient briefly to find a staff member who speaks their language.
Right.
Or try to find a translation card.
Leaving a patient in a burning room to find a translator is essentially abandoning them to die.
It is absolute abandonment. In a life-or-death scenario, you bypass verbal communication entirely.
So what do? Just grab them?
You use urgent, clear physical guidance. You take their arm firmly, you use broad, unmistakable hand gestures pointing toward the door, and you physically move them out of the danger zone.
Wow, okay.
You rely on universal human body language, panic, and movement.
That makes complete sense. The physical action overrides the language center of the brain. Now, when we're moving these patients out, especially the ones in wheelchairs or beds, we need to get them downstairs. I know the rule is to avoid elevators, but I want to understand the why. If an elevator can move 10 people down 4 floors in 30 seconds, why are we dragging them down the stairs?
It's a great question because the elevator seems like the perfect escape pod, right? But in a fire, An elevator shaft acts like a massive chimney.
Oh, wow.
Yeah, the heat and smoke are naturally drawn into the shaft and rapidly pulled upward. If you're in that elevator car, you can quickly succumb to smoke inhalation.
That's terrifying.
And furthermore, fires destroy electrical systems. If the power cuts out, that elevator car stops between floors, and you have just locked a group of vulnerable patients inside a metal box filling with toxic smoke.
That is a horrifically vivid image. Okay, so elevators are essentially death traps during a fire. You take the stairs, period.
Always the stairs, and you do it immediately. Another distractor on the test is wait for administrative staff to issue evacuation orders over the loudspeaker.
Oh, no.
You do not wait. When the alarm sounds, you execute the facility's evacuation plan instantly.
Which is exactly why drills exist. I mean, I remember doing fire drills in school, and it always felt like a break from math class. But in a hospital or nursing home, the stakes are completely different.
They really are. And you'll likely see a question asking about the primary purpose of a fire drill. The wrong answers will downplay it. They'll say the purpose is to test if the alarm bells are working or to comply with local fire codes.
So what is the actual purpose?
The primary purpose is muscle memory. It's to ensure that all staff and patients can execute the evacuation procedures efficiently without having to stop and think.
When panic sets in, you can't think straight.
Exactly. Higher-level cognitive reasoning shuts down. You revert to your training. The drill literally trains your nervous system on where to walk, how to move, and who to grab, so you can do it automatically when the hallway is actually full of smoke.
Okay, so we've been dissecting localized emergencies inside the building, where the danger is basically born inside the walls. But statistically, the building itself is usually the safest place to be, unless, of course, the threat is coming from the outside. So let's look at natural disasters. Tornadoes and floods.
I love looking at these two side by side because the physical mechanics of the emergencies are total opposites. The protocols are literally mirror images of each other.
Let's start with wind. A tornado warning is issued. You look out the window, the sky is green, the sirens are going off. The danger vector is a 200-mile-per-hour wind sweeping across the landscape.
Yep.
Logically, you want to put as much mass between the patients and that wind as possible.
Exactly. So your protocol is interior, low, and windowless. You move patients to hallways or rooms in the absolute center of the lowest floor of the building.
You want those heavy walls around you.
You want the load-bearing walls of the structure surrounding you. You want to be far away from exterior glass, which turns into lethal shrapnel under that kind of wind pressure.
The distractors for the tornado questions are almost comical if you think about the physics. Like, one option suggests taking all the patients outside to the parking lot,
which exposes them directly to flying debris and the funnel itself.
And my absolute favorite wrong answer, lock all the doors and windows to keep the tornado out.
As if a deadbolt is going to hold back a force of nature that can rip asphalt off a highway.
Right.
It's absurd, but when test takers are anxious, they see the word lock and immediately associate it with safety. You have to think about the physical mechanism of the threat. A tornado crushes the exterior of a building, so you retreat to the interior core.
Right. Go down, go in. Now, contrast that with a flood. The physical mechanism of a flood is rising water. It attacks the foundation and the lowest levels first.
So if a tornado means go down and in, a flood means go up.
Simple as that.
If you're evacuating non-ambulatory patients during a flood warning, you follow the facility's plan to move them vertically. Up to higher floors using available equipment like stair chairs or elevators, assuming power is still safely active prior to water breach, of course.
There is a really specific warning in the study materials about wheelchairs and floodwaters, though.
Yes, there is.
Let's say the ground floor has an inch or two of water coming in. Why shouldn't I just quickly push a patient in their wheelchair across the lobby to the stairwell?
Because moving water is deceptively powerful. Even just a few inches of flowing water carries immense kinetic energy.
Yeah.
When you push a wheelchair into it, the solid wheels and the frame act like a sail catching the current.
Oh, wow. I never thought of it like that.
It takes very little force to knock a wheelchair sideways or sweep it away entirely. Furthermore, muddy floodwater hides hazards, open maintenance covers, debris, drop-offs.
You can't see where you're walking.
Exactly. If the chair tips over in flowing water, a non-ambulatory patient is instantly in a drowning situation. You never try to navigate floodwaters. You move up, staying dry.
That is a phenomenal visual. The wheelchair acting like a sail. Oppose the vector of the threat. Water rises, so you rise. Wind attacks the outside, so you go inside.
That is the core logic of disaster response.
Okay, we've covered the macro disasters, the whole building scenarios. But I want to zoom in now. I want to look at the micro disasters, the immediate, localized, individual medical crises where the timeline shifts from minutes down to seconds.
The really scary ones.
Yeah. Choking, seizures, and bleeding.
These are the moments that truly test your clinical observation skills. Let's look at choking. Specifically, the difference between a partial and a complete airway obstruction.
This is a scenario where well-meaning people constantly mess up.
All the time.
Say you're in the dining hall. A patient takes a bite of dried chicken, and suddenly they start coughing violently. Their face is turning red. Every instinct tells you to run over and start smacking them on the back.
And that is exactly what you should not do. If a patient is coughing forcefully, their airway is only partially obstructed. Air is still moving in and out of their lungs, which is exactly why they can cough.
So they're actually protecting their own airway.
Exactly. A strong cough is the human body's most effective defense mechanism for clearing an obstruction. If you run over and start whacking them on the back while they're sitting upright, you run the risk of physically knocking the piece of food further down their trachea.
Oh, no.
You could turn a partial obstruction into a complete one.
So if they're coughing, what is my role?
You observe them closely, and you verbally encourage them to keep coughing. You let their anatomy do the work.
But the exam specifically targets the other scenario, right? The complete obstruction.
Yes. And when it's a complete obstruction, it's actually terrifyingly silent. The patient cannot speak, they cannot cough, and they're not moving air.
They usually grab their neck, right?
Yes, they might be clutching their throat, the universal choking sign. Their face may begin to turn blue, a condition called cyanosis, because oxygen is no longer reaching their blood.
So what is the physiological mechanism of what we do next, the Heimlich maneuver? Why does pushing on someone's stomach pop a piece of steak out of their throat?
It's pure physics. The Heimlich maneuver, or abdominal thrusts, utilizes the patient's own anatomy against the obstruction. Below the lungs is a large dome-shaped muscle called the diaphragm. Even when you fully exhale, your lungs still hold a reservoir of residual air. When you stand behind the patient, make a fist, and pull forcefully inward and upward just above their navel, you are rapidly shoving the diaphragm up into the lungs.
Oh, I see. You're turning the diaphragm into a piston.
Exactly. You're acting like a bellows.
Yeah.
That sudden, violent upward pressure forces the residual air trapped in the lungs up the windpipe. That column of pressurized air hits the obstruction from below and pops it out like a cork from a champagne bottle.
That is incredible. And you have to do it immediately, right? There's no wait and see.
No waiting. Brain death from lack of oxygen begins in mere minutes. You immediately begin abdominal thrusts and you call for someone else to get the nurse or call a code.
Right.
And let's look at the worst possible distractor on the exam for this scenario. Offer the patient a glass of water to help wash the food down.
Which sounds completely logical if you have a pill stuck in your throat. But in a complete airway obstruction, it's a death sentence.
It really is. The airway, the trachea, is completely blocked. If you try to force water down their throat, it cannot go into the stomach because the esophagus and trachea share an opening at the top.
So where does the water go?
It will just pool above the blockage. If the obstruction shifts even slightly, that pooled water will immediately drain into their lungs, drowning them from the inside. Never, ever give a choking victim liquids.
Turning the diaphragm into a piston. And absolutely no water. Got it.
Good.
Let's look at another terrifying acute crisis, seizures. I think seizures frighten people because the human body is suddenly doing things that look incredibly violent, and it feels like you should be physically intervening to stop it.
It's deeply unsettling to witness because it's essentially an electrical storm in the brain. The normal, organized electrical impulses that control muscle movement suddenly misfire wildly, causing the violent muscle contractions and flailing we associate with a grand mal seizure.
So, as a CNA, how do I manage that electrical storm?
The short answer is you don't. You cannot stop the seizure. Your entire job is to manage the environment around the patient to prevent secondary injuries.
Okay.
The golden rule for seizure management is incredibly simple, and actually, on the CERT Prep Academy materials, they use a fantastic mnemonic for this: side, safe, and summon.
Oh, I like that. Side, safe, summon. Let's unpack that. Why side?
You roll the patient onto their side to utilize gravity. During a seizure, a patient loses control of their swallowing reflex. They often produce excessive saliva, or they may vomit.
Which is an aspiration risk.
Huge risk. If they are lying flat on their back, that fluid will pool in the back of their throat and drain straight down their windpipe into their lungs. This causes aspiration pneumonia, which can be fatal days later.
But on their side.
By rolling them onto their side, gravity pulls the tongue forward, keeping the airway open, and allows any smooths to safely drain out of the corner of their mouth onto the floor or a pillow.
That makes perfect anatomical sense. The side position turns the mouth into a drain rather than a funnel. So that side, what about safe and summon?
Safe means clearing the environment. You move hard furniture out of the way. You place a soft pillow or folded blanket under their head so they aren't repeatedly slamming their skull against the floor during the convulsions. You loosen tight clothing around their neck.
And summon?
Summon simply means calling for the nurse immediately so they can track the duration of the seizure and prepare emergency medications if it doesn't stop.
Let's debunk the myths, because the wrong answers on this topic are based on terrible advice that has been floating around for decades. The biggest one: putting a wallet or a spoon in their mouth so they don't swallow their tongue.
Oh, I hate that one. It is anatomically impossible to swallow your own tongue.
Wait, really? Impossible?
Impossible. Your tongue is anchored to the floor of your mouth by a thick band of tissue called the frenulum. You cannot swallow it. If you try to pry a seizing person's jaw open to shove a hard object inside, the extreme force of their jaw muscles clenching will either shatter their teeth, break their jawbone, or sever your fingers. Plus, whatever you put in there immediately becomes a fatal choking hazard.
Okay, so absolutely no objects in the mouth, and I assume we aren't trying to pin their arms and legs down either, right?
Never restrain them. The muscle contractions during a seizure are incredibly powerful. If you hold a flailing limb down, the opposing forces can easily dislocate a joint or fracture a bone. You let the seizure run its course organically. Side, safe, summon.
It's all about facilitating safety rather than forcing control.
Exactly.
Let's shift to a more clinical emergency. The pulled-out IV. You walk into a room to check on a patient. You notice their IV line is dangling off the bed, the needle is totally out of their arm, and there is a small pool of blood forming on the bed sheets. What is your immediate priority?
This question is a brilliant trap because it tests two distinct things simultaneously: your emergency response prioritization and your understanding of your scope of practice.
Okay, so what's the move?
The only correct action is to put on gloves, apply firm, direct pressure to the bleeding site with a clean gauze or cloth to stop the hemorrhage, and hit the call light for the nurse immediately.
So applying pressure is basic first aid, but the distractors on the test are so sneaky. One of them says, clean up the blood and change the bed linens immediately to prevent infection.
Right. And changing linens is a core CNA task. You spend half your day doing it, so it sounds like a responsible answer. But changing sheets is not an emergency response.
The patient is still bleeding.
Exactly. While you're stripping the bed, the patient is continuing to bleed. You prioritize the physiology of the patient over the cleanliness of the environment. You stop the leak first.
Another distractor says, carefully reinsert the IV needle and tape it securely. I mean, it just popped out, right? Can I just slide it back in?
Absolutely, unequivocally no.
Just checking.
Reinserting an IV means you are puncturing a vein and introducing a foreign object directly into the patient's bloodstream. That is a sterile, invasive procedure that falls strictly under the license of a registered nurse or a doctor.
So it's totally out of scope.
Completely. The CNA doing that is practicing medicine without a license. It is a massive legal and safety violation. You do not touch the IV bag, you do not silence the beeping IV pump, and you do not manipulate the tubing. You apply pressure to the arm, and you summon the nurse.
It's a great reminder that knowing what you are not allowed to do is just as important as knowing what you must do.
Well said.
We've spent a lot of time on adrenaline-pumping disasters, fires, tornadoes, choking. But let's bring it back to reality. Statistically, the thing that is going to injure your patients the most isn't a 200-mile-per-hour wind. It's gravity.
So true.
The quiet, everyday, relentless disaster is the patient fall.
Falls are the true epidemic in healthcare facilities. They are the most common daily emergency, and they often lead to a devastating downward spiral in an elderly patient's health.
Yeah, a broken hip is a huge deal.
A broken hip can lead to bed rest, which leads to pneumonia, which can be fatal.
Yeah.
The best emergency procedure for a fall is entirely preventative.
The exam clearly wants you to be able to spot the danger before gravity takes over. Let's look at the profile of a high-risk patient. The question asks you to identify who is at the highest risk for falls.
Okay.
The correct answer is an 82-year-old patient on multiple medications who is confused and has poor vision. Let's dissect why that specific combination is a ticking time bomb.
It's about compounding vulnerabilities. Age alone brings some muscle weakness and slower reflexes. But the real kicker here is polypharmacy. the medical term for being prescribed multiple simultaneous medications.
Right. I think of polypharmacy like running too many heavy software programs on an older computer at the same time.
That was a good way to look at it.
Eventually, the RAM gets overloaded, the system starts to lag, signals get crossed, and the computer just crashes. In a human body, that system crash presents as sudden dizziness, profound drowsiness, or a massive drop in blood pressure when they stand up.
That is a brilliant analogy. Their internal software is glitching. Then you layer on confusion. A confused patient doesn't remember that their software is glitching. They don't remember that they have a weak hip or that they get dizzy.
They just try to get up and go.
They just decide they need to go to the bathroom, so they stand up without waiting for help. And finally, you add poor vision. They can't see the electrical cord stretching across the floor or the puddle of water near the sink. They are dizzy, they are impulsive, and they are flying blind. It's a guaranteed recipe for a fall.
You contrast that with the distractors. A 60-year-old recovering from abdominal surgery or a 50-year-old with a broken arm. The 50-year-old just has a heavy cast. The 60-year-old has pain, but their mind is sharp and their vision is fine.
Right.
The 82-year-old has systemic overlapping failures.
Exactly.
So if I'm watching this high-risk patient walk down the hall using their walker, what specific physical mechanics should make my CNA spidey sense dingle?
You're watching their feet. Specifically, you're looking for shuffling.
Shuffling. I think a lot of people just assume shuffling means the patient is tired or lazy.
And that assumption gets people hurt. Shuffling is a massive biomechanical red flag. When you walk normally, you lift your foot, clearing the ground, and plant it forward.
Right.
If a patient is shuffling, they are sliding their soles along the floor. They are not achieving ground clearance. That means even a millimeter of change in the floor surface, the slight metal strip where tile meets carpet, or slightly uneven floorboard will catch the tip of their shoe.
Oh. And they trip.
Because their balance is already compromised by age or medication, that tiny toe catch instantly pitches their center of gravity forward, and they cannot step fast enough to catch themselves.
So a shuffle isn't just fatigue, it's an impending trip hazard masquerading as a walk.
Exactly.
Let's talk about the patients who don't even know they are at risk. Patients with dementia. They wander, they forget their limitations. How do we keep them safe? Because the instinct of an exhausted caregiver is just to put them in a deep chair and tell them not to move.
And the distractors on the test reflect that exact tired instinct. One incorrect option says, limit the patient's activities to prevent falls. Another might suggest using a physical restraint, like a lap belt or a vest, to keep them safely in bed or in a chair.
Why are restraints the wrong answer, though? If they keep getting up and falling, doesn't strapping them in solve the problem?
It actually creates a much worse problem. First, from a physiological standpoint, if you restrict a person's movement entirely, their muscles rapidly atrophy. It's called deconditioning.
Oh, wow.
So when they eventually do get up, they are drastically weaker, and their fall risk is exponentially higher.
That makes sense. You use it or you lose it.
Exactly.
Yeah.
Second, the psychological response to being restrained is usually severe panic and agitation. A patient with dementia doesn't understand why they are tied down. They just know they are trapped. They will fight the restraint.
Which just causes more injuries.
Yes. They will try to wriggle out of a lap belt or attempt to climb over the side rails of a bed while their body is still tethered. This leads to horrific outcomes where patients become entangled, strangled, or fall from an even higher, more awkward position because they are fighting the equipment.
So restraints are completely counterproductive. They increase the severity of the injury. What is the solution then?
The standard of care is aggressive environmental modification and close supervision. You keep the area well lit. You remove every single tripping hazard.
Just clear the path.
Right. If they want to wander, you create a safe, clear path for them to wander in. You engage them in structured activities to burn off that restless energy.
Let's talk about those environmental hazards because it's not just clutter. There's a scenario about a patient leaving the water running in the sink and a puddle is forming on the tile. The question asks what you, the CNA, should do.
The answer is remarkably simple, yet people overthink it. You walk over, turn off the faucet, grab a towel, and wipe up the floor immediately.
The distractors are great here. One says, report it to the nurse, but do not touch the water, as if the water is radioactive.
Right. Or ask the patient to clean it up since they caused it. That is punitive and dangerous. You're asking a patient with poor balance to bend over a slippery floor.
Yeah, that's a terrible idea.
You have real-time authority and responsibility to correct environmental hazards. You don't need a committee meeting to wipe up a puddle.
Let's move to the bed itself. A lot of falls happen when patients are transitioning in and out of bed. The general rule is to keep the bed in the lowest possible position, right?
Always. Unless you're standing right there actively providing care like changing a dressing or rolling them for a bed bath where you raise it to save your own back, that bed must be low to the ground.
It's a basic geometry. A fall from 12 inches off the ground results in a bruise. A fall from 36 inches off the ground results in a shattered pelvis. Yeah.
Exactly. Now let's look at a nightmare scenario regarding bed safety. You have a confused patient. They are in bed, the bed is low, and the side rails are up. You walk in, and you see the patient actively throwing their leg over the top of the side rail, attempting to climb out.
Oh boy.
What is your immediate action?
My first thought is, lower the rail. If they're going to climb over and fall from the very top of the rail, they're going to land on their head. If I lower the rail, they can just slide out normally.
That logic is exactly why lower the side rails immediately is such a tempting distractor on the exam.
Yeah.
But think about the cascading consequences.
Right.
The patient is confused and unsteady.
Right.
If you lower the rail, you are essentially opening the gate and giving an unsupervised, unsteady patient full permission to exit the bed alone. They're almost guaranteed to fall the second they try to stand up.
Okay, so I don't lower the rail. Do I try to physically shove them back into bed?
No, because engaging in a physical wrestling match with a confused patient usually causes them to fight harder, increasing the risk of injury to both of you.
So what do I do?
The correct action is to remain right there at the bedside to provide a physical blockade so they cannot finish climbing over. You use a calm, soothing voice to de-escalate their panic. Mr. Smith, let's get your leg back under the covers. It's not time to get up yet. And while you are blocking them and talking to them, you hit the call light or shout into the hallway for backup.
You contain the situation with your presence, not your physical force.
Exactly.
Let's look at one more psychological trap that leads to falls. Juggling multiple patients. You're the only tech in the room. You're actively holding a gait belt, helping Mr. Jones walk from his bed to the bathroom. He's unsteady.
Okay, picture painted.
Suddenly, the call light goes off for Mr. Davis in the other bed. He says he needs help right now. What do?
This question tests your ability to prioritize acute physical safety over customer service speed. The correct action is to verbally acknowledge Mr. Davis. Say, "I hear you, Mr. Davis. I will be right with you in just a moment." But you absolutely must finish safely assisting Mr. Jones to his destination first.
Why can't I just say, Mr. Jones, stand right here for 5 seconds, hold on to the wall while I run over to see what Mr. Davis needs?
Because the moment you let go of that gait belt and step away, you have abandoned an actively ambulating, unsteady patient. If Mr. Jones falls while you're checking on Mr. Davis, you are completely liable.
Oof, yeah.
Verbal acknowledgement reduces Mr. Davis's anxiety. He knows he isn't being ignored, which reduces the chance he will try to get up by himself in frustration. But your physical hands remain committed to the patient currently fighting gravity.
Secure the current load before taking on a new one. That makes perfect sense.
Right.
All right, we have spent a massive amount of time talking about protecting the patients from gravity, and now we need to talk about protecting you. Let's transition into the physical work of safety. Body mechanic.
Huge topic.
Because if you blow out your lumbar spine during your first month on the job, your career is over.
Body mechanics is the science of using your musculoskeletal system efficiently to avoid injury. It's heavily tested because back injuries are the #1 reason CNAs leave the profession.
Let's break down the physics of lifting. The scenario is, you need to lift a heavy box of medical supplies from a low shelf near the floor. Walk me through the perfect mechanical lift.
It starts with your foundation. You spread your feet shoulder-width apart. This creates a wide base of support, lowering your center of gravity and making you vastly more stable.
Okay, wide base.
Then, you bend at your knees and hips, you squat down. You do not bend at your waist with straight legs.
Right, because if you bend at the waist, your upper body acts like a giant lever, and your lower back is the hinge taking all the sheer force.
Exactly. Once you're squatted down, you pull the heavy object as physically close to your torso as possible. The further away a weight is from your center of gravity, the exponentially heavier it feels to your spine.
Keep it close.
Then, you drive upward using your quadriceps and your glutes. These are the largest, thickest, strongest muscles in the human body. You let the legs do the work, keeping your back in its natural neutral alignment.
What is the absolute cardinal sin of lifting, the thing that causes the most catastrophic injuries?
Twisting your spine while carrying a load.
Let's use a metaphor here. I've always heard the spine compared to a stack of wet plates. If you press straight down on a stack of wet plates, which is what happens when you lift with good posture. They are incredibly strong and stable.
Yeah, they can hold a lot of weight.
But if you put weight on top of that stack and then try to twist the plates,
the plates instantly slip out from under each other. That is exactly what happens to the discs in your spine. Torsion twisting under a heavy load creates massive shearing forces that rupture spinal discs.
ouch.
If you're holding a patient or a heavy box and you need to change direction, you do not twist your torso, keep your torso rigid, and you physically pivot your feet to turn your entire body as a single unit.
Pivot the feet, protect the plates. I love that. Let's apply these mechanics to a human being. Ambulation and gait belts. I am walking down the hall with a patient who recently had a stroke. Their left side is profoundly weak. Logically, where should I stand?
You must stand on the patient's weaker side, usually slightly behind them, holding the gait belt with an underhand grip.
No, I know that's the rule, but I want to push back on it because it feels so counterintuitive. If their left side is basically useless, shouldn't I stand on their right side, their strong side, so they can reach out and grab my arm for balance?
It feels logical, but it is biomechanically flawed. Think about how a collapse happens. If the patient's left leg buckles, they are not going to fall to the right. They're going to fall toward the weakness.
Oh, they're going to collapse to the left.
Exactly.
So if I am standing on the right, watching them fall to the left, I am completely useless. I can't reach across their body to stop them.
Precisely. By positioning yourself on your weak side, you are essentially acting as a flying buttress on a cathedral. You are a structural brace reinforcing the failing wall.
Oh, that's a great image.
If that weak leg buckles, you're already underneath their center of gravity on the collapsing side. You can use your own body and the leverage of the gait belt to catch their weight and stabilize them against your hip.
You guard the weak point. That makes total sense when you visualize the collapse. Which brings us to arguably the most intense scenario regarding body mechanics on the entire exam. The commode scenario.
Oh yeah, the big one.
You're assisting a heavy patient. They are standing near the commode. Suddenly, they get lightheaded. Their eyes roll back. Their knees completely buckle and they begin to fall. You're holding the gait belt. What is your immediate physical reaction?
This scenario is testing your ability to override your most deeply ingrained human instinct. Your brain is going to scream at you to catch them.
Naturally.
You'll want to plant your feet, grip that belt, lean backward, and try to physically yank them back up to a standing position to prevent them from hitting the floor.
Because hitting the floor feels like failing, we're supposed to prevent falls.
You must let go of the idea of prevention once gravity's already won. If a 200-pound dead weight is dropping toward the floor and you attempt to arrest that momentum with your arms and lower back, you are going to snap your spine.
And then you're both on the floor.
Exactly. You're both going to end up in a crumpled, severely injured heap.
So what is the alternative? I can't just let go and watch them faceplant into the tile.
You execute what we call a controlled fall. You widen your stance immediately to create a solid base. You maintain a firm underhand grip on the gait belt. Instead of pulling up, you pull them firmly against your own body, and you use the belt to gently slide them down the length of your own leg to the floor.
Like a ramp.
Yes. You bend your knees and descend with them.
You guide the trajectory of the crash.
Exactly. You are acting as a human parachute. A free fall from a standing height onto hard tile results in shattered hips, fractured skulls, massive internal trauma. A controlled, guided slide down your leg reduces that kinetic impact to almost nothing.
That's amazing.
Once they are safely on the floor, resting comfortably, then you check for injuries and call for the nurse.
It requires such a massive perspective shift. You aren't failing to stop a fall. You are successfully executing a controlled descent to prevent catastrophic trauma.
That is exactly the mindset the exam wants you to have.
Control the descent. That is a phenomenal takeaway. All right, we have covered the acute crises, the environmental hazards, and the physics of the human body. Let's transition into our final major section for this deep dive: scope, rules, and equipment boundaries.
Very important section.
Because sometimes keeping a patient safe isn't about physical strength. It's about knowing the legal and ethical boundaries of your role and enforcing facility rules, even when it is incredibly uncomfortable.
This section of the exam tests your professionalism and your understanding of the hierarchy of healthcare. It's about knowing when to stop and ask for help.
Let's start with equipment safety, mechanical lifts, like a Hoyer lift. The scenario is you have a patient suspended in the sling of a mechanical lift. You're moving them from the bed to the wheelchair. You are halfway through the transfer, swinging them through the air, and the patient suddenly cries out, "Stop! My shoulder is in agonizing pain. What do you do?
The exam writers know exactly what you are thinking. You're thinking, well, we're already halfway there. It'll take longer to put them back in bed. Let's just speed up, drop them in the chair, and then figure out the pain.
Exactly. Just power through it so they can be sitting safely.
And that is the exact wrong move. One of the distractors is literally increase the lifting speed to complete the procedure quickly. If a patient reports sudden, acute pain during a mechanical transfer, you stop the machine immediately.
Why stop midair?
Because sudden pain is a biological alarm bell, indicating that mechanical trauma is currently happening. Maybe the canvas sling was positioned improperly and is aggressively compressing a major nerve bundle in their armpit.
Ouch.
Maybe a piece of the metal frame has pinched their skin. Or even more terrifying, maybe the patient has an undiagnosed hairline fracture in their shoulder from a previous bump, and the pulling force of the sling is actively tearing the bone apart.
Oh my gosh.
If you ignore the alarm and keep moving, or speed up, you turn a temporary pinch into permanent nerve damage or a compound fracture.
That is horrifying. So you stop the machine.
You stop the movement. If possible, you gently lower them back to the bed or adjust their position slightly to relieve the immediate tension, and you shout for the nurse to assess the patient. You do not proceed.
That rule of stopping and checking applies to everything, doesn't it? When am I supposed to actually inspect the equipment I use every day?
The golden rule of equipment is pre-flight checks. You always check equipment for damage, proper function, and safety features before every single use. You do not assume the wheelchair brakes work just because they worked yesterday. You physically test them. You check the electrical cords on the beds for fraying.
There's a really bad distractor on the test that says, check equipment only after a patient has complained about it functioning poorly.
That is reactive healthcare, and reactive healthcare gets people injured. You are the proactive first line of defense.
Let's talk about a piece of equipment that is literally everywhere in a nursing facility: oxygen therapy. We know oxygen helps people breathe, but from a purely safety-focused perspective, what is the critical danger?
Oxygen is a chemical accelerant.
It's important to clarify that oxygen itself doesn't explode, right? It isn't flammable on its own.
Correct. But it aggressively feeds fire. It lowers the ignition point of everything around it and makes things burn exponentially hotter and faster.
So even a tiny spark.
A tiny spark from static electricity or a match that would normally just extinguish itself will instantly flare into a massive fireball in an oxygen-rich environment. Therefore, the absolute rule is no open flames, no matches, no lighters, and no smoking materials anywhere near a patient receiving oxygen therapy.
This is one of those scenarios where the CERT Prep Academy materials really shine.
Oh, yeah.
They walk you through exactly how the exam frames these boundary and safety risk questions. And actually, if you look at the free study guides on CERT Prep Academy, they highlight another daily safety check that seems mundane but causes massive injuries: bathwater temperature.
Oh, the bathwater question.
Yeah.
Yes. Elderly residents undergo physiological changes to their skin. The dermal layers thin out significantly, and they often suffer from neuropathy, which is a reduction in nerve sensation.
Meaning they might be sitting in scalding water and not actually feel the heat until second-degree burns have already formed?
Exactly. Their internal thermostat and pain receptors are compromised. So the absolute maximum water temperature for patient bathing to prevent scalds and burns is legally set at 110 degrees Fahrenheit, which is about 43 degrees Celsius.
And I have to check that myself.
You, the CNA, must physically test the water temperature yourself with a thermometer or your inner wrist first. You then have the resident confirm it feels comfortable to them, but you never let it exceed that 110-degree hard limit, regardless of how hot they say they like it.
That brings up a fascinating conflict. What happens when safety protocols directly clash with patient autonomy?
This is a tough one.
Let's say a patient is notoriously unsteady on their feet. You go to assist them to the dining hall, and you pull out your gait belt. The patient looks at it and says, "Absolutely not. I hate that thing. It pinches my stomach. I am not wearing it." What do? Do you just quickly buckle it on them anyway because it's for their own good?
No. You cannot force a safety device onto a conscious, competent adult who is refusing it. That is considered battery. A patient retains the fundamental legal and ethical right to refuse any care or equipment.
But logically, I know they're going to fall without it. It feels negligent to let them walk without it.
It is an incredibly stressful position for a caregiver. But your boundary is very clear. The correct response and the answer they want on the exam is a three-step process. First, you educate. You calmly explain why the gait belt is necessary for their safety and try to encourage their cooperation. Mr. Smith, I know it's uncomfortable, but it really helps me keep you steady so we don't have an accident on the way to lunch.
Okay, so I try to persuade them. What if they still say no?
If they persist in refusing, step 2 is you respect their autonomy. You do not force it. Step 3 is you immediately notify the nurse.
Can I use a little leverage? Like, Mr. Smith, if you don't wear the belt, the facility policy says we have to discharge you.
Absolutely not. That is a distractor on the exam, and it is a massive violation of patient rights. Threatening a patient, coercing them, or threatening discharge is abusive.
Oh, wow. Good to know.
Your job is to educate, respect the refusal, and report the refusal to the nurse. The nurse will then take over the clinical conversation to assess why the patient is refusing and document the assumption of risk. Your physical boundary stops at education and reporting.
That is such a crucial distinction. Education and reporting. Let's look at another boundary scenario where the patient is begging you for something that violates a medical order.
Right.
The NPO order. NPO stands for nil poros, which is Latin for nothing by mouth. The scenario is, a patient is scheduled for abdominal surgery in 2 hours. They are strictly NPO. You walk in and they are begging you for a sip of water. They say their throat is parched and they are incredibly uncomfortable. What do you do?
This is one of the hardest things to endure emotionally because your entire job description is built on providing comfort. But you have to be absolutely uncompromising. You tell the patient that they must ask the nurse, and you do not provide any water. Not a glass, not a sip, not a drop.
The distractors try to negotiate with you here, don't they? One of them says, give the patient a small cup of ice chips to moisten their mouth, since ice isn't really food or a full drink.
That is a deadly distractor. Ice chips melt rapidly into water in the stomach. An NPO order prior to surgery is not a suggestion. It is a critical safety protocol to prevent a fatal complication during anesthesia.
Let's look at the physiology of that. Why is water in the stomach so dangerous in the operating room?
When a patient is put under general anesthesia, all of their muscles paralyze, including the sphincter at the top of their stomach that keeps contents down, and the reflex that protects their windpipe.
Oh, I see where this is going.
If there is any liquid or food in the stomach, it can easily flow passively up the esophagus and drain straight down into their lungs while they are unconscious. This is called aspiration, and it causes massive chemical damage to the lungs and severe pneumonia, which can easily kill a patient recovering from surgery.
Wow. So by giving them a single ice chip to be nice, I am actively loading a gun that could go off in the OR.
Precisely. You must reinforce the physician's orders, even when the patient is uncomfortable or angry with you. You are enforcing a boundary of life and death, not just comfort.
That makes it so much easier to say no when you understand the physiological consequences. All right, let's hit one final boundary scenario, and this one has to do with facility security.
Okay, let's hear it.
You're walking down the main corridor, and a visitor, someone wearing street clothes, no badge, stops you and asks, "Excuse me, can you tell me where the main electrical panel for this wing is?" What is your response?
You politely decline to provide that information, and you direct them to speak with administration or the security desk.
My customer service instinct wants to just be helpful and point down the hall. Yeah, it's just past the elevators on the left. Why is that wrong?
Because a healthcare facility is full of vulnerable people and sensitive equipment. Electrical panels, oxygen storage closets, medication rooms, and IT server rooms are restricted areas for profound security reasons.
That makes sense.
If a random person wants access to the electrical grid that powers the life support ventilators, you do not hand them the map. Directing a stranger to a critical infrastructure point creates a massive security vulnerability.
Okay, so I don't tell them where it is, but there's a distractor on the test that says, tell the visitor that the information is confidential and you cannot help them.
Right, and that answer is incorrect because of its tone. Saying it's confidential and I can't help you is combative and dismissive. It escalates the situation.
So how should I say it?
The correct approach is a professional redirection. You say, "I'm sorry, I can't assist you with that, but the security desk right up front would be happy to help you." You maintain the security boundary while remaining completely professional.
It's all about knowing your limits, whether it's the MPO order, the mechanical lift, the gate belt refusal, or the random visitor. It all boils down to knowing exactly where your scope of practice begins and where it hits a brick wall. You assess the situation, you maintain safety within your limits, and you report everything else to the nurse or administration.
That really is the essence of the CNA role, synthesized into one sentence. You are the eyes and ears, you manage the immediate environment, and you escalate the medical and ethical decisions.
All right, this has been an incredibly dense, fascinating deep dive. We've pulled apart the physics, the psychology, and the physiology of safety. But as we wrap up, I want to leave you, the listener, with a final thought to mull over. We have spent an hour talking about what protocols to execute when the emergency happens. But what should your mindset be before the alarm ever rings?
I think the ultimate takeaway here is that true safety isn't just about memorizing a sequence like RACE or knowing which fire extinguisher to grab. It is about cultivating a mindset of situational awareness.
Situational awareness, I like that.
It's training your brain so that when you cross the threshold into a patient's room, before you even say good morning, your eyes are involuntarily scanning the environment. You instantly spot the slight wrinkle in the throw rug. You hear the faint sound of running water in the bathroom. You notice the lighter sitting on the nightstand next to the oxygen concentrator.
It becomes like a subconscious radar.
Exactly. When you develop that situational awareness, you prevent the emergency before the protocol is ever needed.
Walking into every single room like a safety detective. I absolutely love that. Okay, let's do a quick 1-minute rapid recap of the absolute heaviest hitters from today's deep dive to lock it in.
Let's do it.
Fire. You follow the RACE protocol, and rescue is always, always first. Move the patient. Electrical fire. You need a Type C extinguisher because water will electrocute you. Natural disasters. Oppose the vector. Tornadoes mean go down and to the interior. Floods mean move up to higher ground.
Perfect.
Choking and they are coughing. Let them cough. Choking and they are silent. Heimlich maneuver immediately to turn that diaphragm into a piston and absolutely no water. Seizure. You can't stop the storm. Get them on their side to drain fluids, clear a safe space, and summon the nurse. Side, safe, summon, never put anything in their mouth.
Never.
Falls. Identify the high-risk patients, think polypharmacy and shuffling. Keep the bed in its lowest position, wipe up spills the second you see them, and if a patient starts to go down on your watch, do not catch them. Use that gait belt to execute a controlled descent and slide them safely to the floor.
That is a perfect summary. If you can understand the why behind those concepts, you are going to absolutely crush the safety section of the NNAAP exam.
And speaking of crushing the exam, do not forget that certprepacademy.com is a completely free resource for you. There is no sign-up required, no paywall, nothing. You can get started right this second.
Highly recommend checking it out.
They have a massive 70-question practice test that mirrors the exact format and difficulty of the real NNAAP exam. They have incredibly detailed free study guides covering every single topic we've discussed today, from the RACE acronym to the MPO boundaries and everything else you will encounter on the test.
The flashcards are great too.
Yes. Plus, they have flashcards to help you drill those key terms into your memory. Everything you need to pass this exam is sitting in one place, and it costs you absolutely nothing. Head over to certprepacademy.com right now. The link is right there in the description of this deep dive.
It's an invaluable tool for taking the theory we discuss here and applying it to the actual multiple choice format you'll face on test day. Use it.
Thank you so much for hanging out with us for episode 6. You guys have got this. Keep studying, keep that situational awareness razor sharp, and when you are ready to tackle the next topic, we will be right here waiting for you in episode 7. Happy studying.